Hypokalemia is the big killer in diabetic ketoacidosis that we have to be vigilant for. This is why we should never be starting our insulin infusion until we know what the patient's serum potassium is. All of these patients are going to be total body potassium depleted because of the osmotic diuresis that you see in DKA. In spite of that, some patients can have a normal or even elevated serum potassium level because of that acidosis. As we start our insulin infusion, that potassium level is going to drop, which is why it's critical for us to know the potassium level before starting insulin. If the patient's serum potassium is less than 3.5, hold the insulin, replete potassium until the potassium is greater than 3.5, then you can start your insulin. If the serum potassium is between 3.5 and 5.5, you can start your insulin and potassium repletion simultaneously. And if the potassium level is greater than 5.5, you can get away with just doing an insulin drip, although I would rather start the potassium in those patients as well, understanding that the next potassium level I get back is going to be significantly lower because that insulin infusion has been started. We have to be aggressive at both identifying hypokalemia and treating it in the patient with DKA so we don't run into severe hypokalemia, which can be a killer.